Thank you very much. My name is Shadrack Piri, laboratory technologist at Kota District Hospital. I would like to present on the guidelines for the clinical use of blood and blood products in Malawi. And here on the introduction, we're going to discuss the following. So blood available for transfusion in Malawi is supplied by Malawi Blood Transfusion Service. So it is mostly tested for transfusion transmitted infections, which are HIV, hepatitis B, hepatitis C, syphilis, and malaria. So the blood products available are whole blood, red cell suspensions. These are found in pediatric and adult packs, fresh frozen plasma, and cryoprecipitates. So not all hospitals have the capacity to store all these blood products. So as for Nkota, um, we only keep the whole blood, red cell suspensions, and fresh frozen plasma. So Nkota District Hospital uses blood from Malawi Blood Transfusion Service. If there is no blood in the blood bank, family replacement blood is used. So family replacement blood donors are strongly discouraged by the Ministry of Health. So blood uh, many clinicians routinely use flutamide before transfusion for the fear of blood of fluid overload. However, there is no evidence based for this practice. Top-up transfusion of 2 to 3 units of red cells in stable patient with no history of signs of cardiac failure or fluid overload will not require flutamide pre-medication. So fluid overload due to transfusion is likely to occur in patients with severe chronic anemia, patients with overt cardiac failure, and severe malnourished children. So fluid overload can be prevented in these patients by either giving furosemide 40 to 80 milligrams for adults and 1 milligram per kg for children, or by reducing the rate of transfusion. Furosemide is obviously not indicated in severe bleeding or hypovolemic patients. So as of furosemide, it should not be routinely used as pre-medication when transfusing blood or blood products. Uh, Ordering and administration of blood. So blood transfusion of safe transfusion of blood and blood products is the responsibility of all professionals involved in the patient care. So getting the right blood or blood product to the right patient at the right time is the key to have the safe blood transfusion. So before prescribing blood products for a patient, consider whether the patient really needs blood to prevent significant morbidity or mortality. So safety can be compromised at any stage of the process, from ordering through the completion of the transfusion and post-transfusion monitoring. So safety can start from, maybe can be compromised at the laboratory when processing blood, or even when ordering blood, then during processing, during transportation, and at the end of transfusion, and even at the monitoring. Safety can be compromised at any stage of this. So before ordering and administering blood, ensure the following one: the patient identification. So you have to identify the patient. Informed consent, very important. So the treating clinician or a member of the treating team who prescribes the transfusion is the only person who may obtain the consent. So the clinician must explain the procedure in terms and the language that the patient understands. The patient should be informed about the common risk and serious and common risk of transfusion, potential benefits of transfusion, alternatives to blood transfusion and their benefits and risks. So risk of the declining transfusion therapy. the patient must have the opportunity to ask a question in case there are other things they have to know. The patient must have the opportunity to make an uncoerced choice. The clinician should document the discussion, the patient's medical chart, and also the patient should sign the consent. So very important. They have to sign. It is recommended that whenever possible, the consent and discussion should occur well in advance of any elective procedure so that there is adequate time to use alternatives. Should the patient so desire, maybe before the electives, it's very important to discuss about the consent of transfusion. In case the patient denies, then you have to find the other alternatives to transfusion. So completion of blood request form. So this is the laboratory request form where you're supposed to document all the required information about the patient and the clinical history, the collection and the labeling of sample for compatibility testing. So safety in blood transfusion, ensure the compatibility of the blood, which is ABO. When we are talking about ABO, we are talking about A, B, and the O blood groups, and also resonance factor, which is negative and positive. So the blood can either be A positive, A negative, B positive, B negative, or resonance positive and or resonance negative. So these are supposed to be screened, and also they have to test for the red cell antibodies, which are IgM and the IgG. So the person collecting blood from the blood bank should bring the written documentation, which is the laboratory request form. Once the blood product has been issued by the blood bank, transfusion should commence within 30 minutes. If it cannot be commenced, it must be stored in the cold chain box at 2 to 6 degrees Celsius for not more than 6 hours, else return it to the blood bank. So cannula and the giving sets for infusing blood must be sterile and must never be reused. Ideally, use flexible plastic cannula. Avoid opening either the cannula or giving set until it is to be used, and avoid touching sterile components. These are some of the infection prevention measures that you can do. So use designated blood giving sets, as they have filters. They have about 20 micrometers in size that fiber out microaggregates and debris. So never use an ordinary IV line for blood transfusion, because those ordinary IV lines, they don't have the filter. So clean the area for cannula insertion with at least 2 clean swabs and surgical spirit or alcohol. So do not use the swab. Do not add any fluid or drugs to the unit before or during transfusion. Remove blood giving set after completion transfusion, and ideally remove the cannula. So cannula and giving sets during infusion, very important. We are supposed to practice the infection prevention measures to avoid all these. So one of the major roles of a nurse in transfusion is monitoring of the patient. So the accurate and quick interpretation of adverse effects can prevent a fatal reaction from occurring. So for each unit of blood transfused, as a minimum, monitor the patient as follows. So before starting the transfusion, 15 minutes after starting the transfusion, 1 hour after starting the transfusion, on completion of the transfusion, 4 hours after transfusion. After completing the transfusion, very important to monitor. So at each of these stages, ask the following how they are feeling. In addition, they got the following information in the patient charts. So supposed to document the patient's general appearance, temperature, pulse rate, blood pressure, respiratory rate, Any abnormal symptoms existing at the start of transfusion should be noted, which are dyspnea, chills, urticaria, lumbar pain. Changes in intensity of these may also indicate the potential for a transfusion reaction and should be assessed clinically. So extra care must be taken in the unconscious patient to monitor and react to changes in vital signs. Excess oozing from the operative site or various access points and unexplained hypotension may indicate that a hemolytic reaction is occurring. So, about the blood products, we said we are having the blood products which we are keeping in our blood bank. So I'll be going through all the blood products that we are giving so that we must have the indications and the full details of these blood products. So we are starting with the red cell products. So red cell products are used to improve tissue oxygenation. So they comprise of whole blood and red cell suspension. So whole blood is a complex tissue from which clinically appropriate components are processed. Many of the components, particularly clotting factors and platelets, deteriorate within hours of donation. So in the whole blood, we don't have the platelets. Now, blood components are therefore made within 6 to 8 hours of blood donation. So the whole blood is collected in those blood bags. Those blood bags has the CPDA1, which is an anticoagulant and stored continuously in a blood fridge for 2 to 6 degrees Celsius and has the maximum shelf life of 35 days. So as for red cell suspension, so the red cell suspensions are prepared from a unit of whole blood from which plasma has been removed from centrifugation in a closed sterile system. So most plasma is removed and uh, there is a sorghum preservative which is added in the red cells to have more lifespan. So for this red cell suspension, they have the lifespan of 42 days. The product, which are the red cell suspensions, they have the hemoglobin of approximately 20 grams per deciliter. And the white cells are not removed in this red cell suspension. So the indication of transfusing these red cell products is as red cell replacement in the absence of red cell suspensions, massive hemorrhage with the possibility of recurrence or continuation, red cell replacement for severe anemia in child with severe malnutrition, red cell replacement is in septicemia patients who remain in shock after appropriate resuscitation with crystalloids. So these are the indications for red cell products, which are whole blood and red cell suspensions. Things to consider before transfusion. So we are supposed to consider the following questions. Is the patient's hemoglobin level low enough that without a transfusion, they would be clinically compromised or at risk of death? Is the decision to give blood solely based on HB level, which is only one aspect of the decision to transfuse, of course, or does the patient have serious clinical signs of anemia for which transfusion is required to relieve? So could the hemoglobin be raised or worsening of anemia be prevented by either treating the underlying conditions, for example, malaria, intestinal parasites, or the hematinics, for example, iron, folic acid, or vitamin B12 when appropriate, for example, acute blood loss. Have you tried volume expansion with intravenous fluid replacement and reassessed to ensure that the patient still require blood? So before transfusion, all these we are supposed to ask these questions so that we really need to see if the patient really needs blood. So the use of red cells in adult medical patient. So take a sample for HB, which is very important before transfusing, ideal as part of full blood count. So before making a decision to transfuse, in some hospitals they don't use HB, but for Nkota we use HB. So in some hospitals they use packed cell volume, which is PCV, or hematocrit. So the hematocrit basically is 3 times HB. For example, when you have the PCV or hematocrit of 30%, that means the HB is 10 grams per deciliter. So when you're having an HB of 5, then you can just multiply 5 times 3, which is the 15% of PCV or hematocrit. So this is the conversion factor for this, in case maybe you go for in other facilities where HB is not commonly used. So there is no observed red cell concentrate transfusion trigger, but the following guidelines are offered. The HB of less than 5 grams per deciliter usually transfuse. HB of greater than 10 grams per deciliter do not transfuse. So HB of between 5 to 10 grams per deciliter. In this, we are supposed to individualize the decision to transfuse by considering the patient's clinical condition. So consider likely the trend of HB, consider rate of change of HB, assess signs and symptoms, assess cardiopulmonary reserve. So very important to assess this. So we have to note that a unit of whole blood or red cell suspension will on average raise HB of 70 kg added by 1 to 5 or to 1.5 milligrams per deciliter. So the use of red cells in OPS and GYNA. So red cells products in OPS and GYNA are indicated in major OPS, hemorrhage, or any loss in the peripartum period, concealed or revealed that endangers life, includes bleeding or abortion, and chronic anemia. So we have to note that the anemia in pregnancy is or if it is the HB of less than 11 grams per deciliter in the first and third trimester, and the 10.5 grams in the per deciliter in the second trimester. So the diagnosis and the effective treatment for chronic anemia in pregnancy is an important way of reducing the need of future transfusion. So that decision to transfuse red cells should not be based on HB levels alone, but also on the patient's clinical condition. Blood loss during normal vaginal delivery or cesarean section does not normally necessitate transfusion, provided that the maternal HB is above 10 grams per deciliter before delivery. So to reduce the wastage of blood, we are supposed to be assessing all these. Indications for red cell transfusion in chronic anemia in pregnancy. So pregnancy less than 36 weeks, HB of less than or equal to 5 grams even without clinical signs or cardiac failure or hypoxia, we are supposed to transfuse. So HB between 5 and 7 grams per deciliter and in the presence of the following condition: established or incipient cardiac failure or clinical evidence of hypoxia, pneumonia or any other serious bacterial infection, malaria, pre-existing heart disease not causally related to anemia. So during duration of pregnancy, 36 weeks or more, if we are having HB of less than 6 grams per deciliter, we are supposed to transfuse, and the HB between 6 and 8 grams per deciliter, and in the presence of the following conditions: established or incipient cardiac failure or clinical evidence of hypoxia, pneumonia or any other serious bacterial infections, malaria, pre-existing heart disease not causally related to anemia. So on elective cesarean section, when elective cesarean section is planned and there is history of APH, PPH, and the previous cesarean section, HB between 8 and 10 grams per deciliter, established blood group, and the cell fresh taken serum for cross matching. So we are supposed to establish the blood group so that we have to be ready for transfusion, and also HB of less than 8 grams per deciliter. 2 units of blood should be cross-matched and available just in case of any complications. So very important to take note of these things. So emergency management of major ops hemorrhage. So basically, they resuscitate, monitor, and investigate. Then they're supposed to stop the bleeding. So these are supposed to be done so that when we are transfusing, we are not wasting blood. So the use of red cells in surgery, in surgical cases. So red cell products are transfused in both surgery and elective surgical conditions. During surgery, the decision to transfuse should be primarily be based on the careful assessment of the volume and the rate, actual and anticipated, of blood loss. The patient's clinical response to blood loss and fluid replacement therapy, and signs indicating inadequate tissue oxygenation. So in both emergency and elective surgery, red cell products are given as part of resuscitation measures after appropriate volume expansion with crystalloids or colloids. In general surgery, consider transfusion if the preoperative hemoglobin level is less than 8 grams per deciliter, and surgery is associated with blood loss of less than 10% of estimated blood volume. The intra or post-op hemorrhage falls, hemoglobin falls below 7 grams per deciliter. So in burns, transfused red cells in patients with less than more than 5% full thickness burns after the shock phase has been successfully managed. When a split skin graft is planned, ensure that the HB is at least 8 grams per deciliter. If the HB is lower than that, then a blood transfusion should be administered, after which the HB should be rechecked before split skin graft is carried out. So for the use of red cell products in elective surgical and gynecological conditions, we are supposed to use the guideline. So basically, for the pediatric transfusion, most of the times we have the problems in this. So pediatric patients may require transfusion for reasons similar to those in adults, but with some additional unique situations, primarily in the neonates. So any of the blood products prescribed for transfusion to adults may be used in children. So basically, neonates, these are the babies within 4 weeks of life following normal gestation age. Infants are children within the first year of life. So pediatric anemia is defined as a reduction in HB concentration or PCV below normal values of healthy children. So in this right hand side, I'm having the normal HB levels of the pediatric, which the day one in the HB is plus or minus 18. 1 month old is 14 grams per deciliter, 3 months 11 grams per deciliter, 6 months to 6 years 12 grams per deciliter, 7 to 13 years plus or minus 13 13 grams per deciliter. So 14 years and above, the same HB levels as the others by sex. So, um, indication for transfusion in neonates, HB of less than 12 grams per deciliter in the first 24 hours of life, we're supposed to transfuse. So HB of less than 12 grams per deciliter in a neonate receiving mechanical ventilation, we are supposed to transfuse. HB of less than 8 to 11 grams per deciliter and oxygen dependent. HB of less than 7 grams per deciliter when stable and off oxygen. So we are supposed to take note of this. In severe malnourished children, fluid overload is a serious complication. So on these children, so we are supposed to give 10 meals per kg instead of 20 meals per kg. So let's consider this, and also in this severe malnourished children, we say it's very important to administer the fluizimide. So here is the flow diagram for management of severe anemia in children of less than 4 weeks old. So we are supposed to be following this flow chart for management of severe anemia. Or those children with the HB of less than 6 grams per deciliter, we are supposed to check for the following if they are present: dehydration, shock, impaired consciousness, heart failure, very high malaria, parasitemia. So if these are available, so we need to transfuse preferably 10 mils per kg of red cells over 3 to 4 hours, or if not available, 20 mils per kg of whole blood. So if these signs are not available, then we have to check the HB if it is less than or equal to 4 grams per deciliter. If it is less than 4 or equal to 4 grams per deciliter, then transfuse. If it is greater than that, then you have to observe. We should not transfuse. So very important to be following this flow diagram so that we have to manage our patients well. So let's talk about the platelets. Platelet transfusion are required for the treatment or prevention of bleeding due to reduced platelet numbers or function. So avoid aspirin and other non-steroidal analgesics and IM injections in patients with significant thrombocytopenia. So platelet concentrates are basically made by centrifugation. They should not be stored in a refrigerator, but they are kept in a special platelet agitator. So transfusion platelet is a standard treatment for bleeding associated with thrombocytopenia and the defective platelet function associated with bone marrow failure, congenital disorders, acute disseminated coagulation, DIC, and massive transfusion with the dilutional thrombocytopenia. So as we said, we have to avoid the aspirin and the other non-steroidal analgesics in those who have the low platelet levels. So patients with the chronic thrombocytopenia who have no symptoms of bleeding do not require platelet transfusion. So indications for platelet transfusion, the decision to transfuse platelets should be based on a combination of clinical and laboratory findings rather than on empirical platelet levels. Transfusion for platelets is a standard treatment for bleeding associated with thrombocytopenia and or defective platelet function in conditions such as bone marrow failure or plastic anemia, acute leukemia, congenital disorders of platelet function, acute disseminated intravascular coagulation, and massive transfusion with dilutional thrombocytopenia. So, when to transfuse platelets into thrombocytopenic patients. So patients with chronic thrombocytopenia who have no symptoms of bleeding do not require platelet transfusion. Patients with acute thrombocytopenia, e.g. post-chemotherapy, should be considered for prophylactic transfusion if platelet count is less than 10, platelet of less than 50, and either post-surgery or major hemorrhage, platelets less than 50, and for most surgical procedures, e.g. laparotomy, liver biopsy surgery, and third-line incision, platelets should be transfused for up to more than 50 liters immediately before surgery. For surgery to the eye or brain or a platelet level of more than 100 is recommended. So platelet transfusion is not required for bone marrow aspirate and biopsy. Application of local pressure is sufficient. So contraindications for platelet transfusion. Platelets are generally contraindicated in patients with immune cause of thrombocytopenia unless there is severe life-threatening hemorrhage, thrombotic thrombocytopenic papilla. Platelet may potentiate thrombosis. Heparin induced the thrombocytopenia, HIT, so may potentiate thrombosis as well. The bleeding pattern in platelet abnormality, or either qualitative or quantitative, are mucocutaneous in nature. So the typical bleeding include diffuse oozing from surgical incisions, cut and petechiae oozing from venipuncture size, gum bleeding, nose bleeding, prolonged messes, retinal bleeding. So, heavy blood loss is unlikely to be due to isolated thrombocytopenia. So, platelet administration and dose, ideally platelets should be transfused through a platelet giving set. However, they can also be given through ordinary blood giving sets. A total dose of platelets should be given over a period of 15 to 30 minutes. For adult, one unit for per 10 kg, which is 5 to 6 units of most adults. In an adult, or 5 to 6 units should be given over 15 to 30 minutes. In adult, approximately 70 kg, one dose for platelets should raise platelet count by 20 when measured 24 hours after transfusion. A poor response may be due to alloimmunization, infection, DIC, splenomegaly, treatment with antibiotics or amphotericin. In some cases, double the dose. So a good clinical, no, if a response is not achieved, a platelet count should be checked 1 hour post-infusion, and the situation discussed with a hematologist if available. So very important to consult. A good clinical response with a poor platelet count is increment. Increment means adequate treatment and is not an indication for administration of more platelets. So febrile, we have to note that febrile non-hemolytic transfusion reaction is a common side effect of platelet transfusion due to the presence of a high number of white cells. So we also keep fresh frozen plasma in our blood bank. So fresh frozen plasma is separated from anticoagulant whole blood within 6 hours of donation. It contains all the clotting factors in normal physiological levels and comes in volume of 400 to 300 ml. must be thawed before use, preferably in a water bath. Laboratory coagulation factors deteriorate within hours of thawing. So basically, when transfusing this, people in the wards, we don't have the water bath, so very important. We can use the laboratory water bath to thaw to thaw before transfusing. So we have to note that we should not be using the hot water so that the FFPs, we should not be using the hot water in the FFPs. So frozen products are brittle. They are very brittle, so the pigtails and the pack in general do not break easily. Therefore, avoid direct handling of plasma packs. So MPTS, they normally issue these in plastic bags to minimize direct handling of the product. So FFP is a hypersmolar due to the additives in the anticoagulant. So large volume transfusion can cause hypernatremia and hypervolemia. So in elderly and very young patients, care should be taken not to precipitate pulmonary edema, especially in cardiopulmonary function is compromised and tissue edema is present. Once thawed, FFPs must be transfused as rapidly as possible, within 15 to 20 minutes per unit. Label coagulation factors deteriorate within few hours of thawing, so we should take note of these. So indications for FFP use, replacement of single factor deficiencies. If single factor concentrates are not available, immediate reversal of warfarin effect, vitamin K deficiency associated with active bleeding, acute de-icing, and the TTP. So these are the indications. So FFPs may be used in massive transfusion or liver disease if there is active bleeding and evidence of disturbed coagulation. So on doses, 15 to 20 mils per kg, minimum dose about 1 liter in an adult. So there is no justification for FFP use in hypovolemia, nutrition supporting protein losing states, and the plasma exchange except in TTP. So we are also very important to monitor the clinical response, the prothrombin time, and also activated partial prothromboplastin time. So very important to monitor all these. Cryoprecipitate, basically we don't have these in our blood bank here at Nkota. So these are insoluble plasma proteins that precipitate out when fresh plasma is rapidly frozen. Indications: hemophilia A, von Willebrand's disease, factor 13 deficiency, hypofibrinogenemia, DIC, dilutional coagulopathies, massive transfusion. So cryopticists are found mostly in the central hospitals. So maximum surgical blood ordering schedule. So maximum surgical blood ordering schedule aims at eliminating unnecessary use of scarce blood and to minimize the cost to the patient or the hospital in elective surgery. Bearing in mind that blood transfusion are not without risk, it is important that all efforts be undertaken to avoid transfusion except where there are absolutely necessary to prevent mortality or significant morbidity. So for use of blood in elective surgery in hospitals in Malawi, in the maximum surgical blood ordering schedule is given as a guide to the number of units of blood that should be reserved for patients with these conditions. So there are There may be exceptionals here. However, when this is the case, written justification must be provided with the order for the reason for needing additional blood. So when we are ordering in these surgical conditions, we are supposed to have the history and also the reasons for ordering more pints at these. So I'll just go in quick for surgical procedures, and here the number of pints to order. So amputation above or knee or below knee, either 0 or 1 pint should be ordered. Bar holes or common bile duct, exploration, mastectomy, splenectomy, so 1 pint, colectomy, which is subtotal, gastrectomy, hip arthroplasty, intra-abdominal tumor resection, major pelvic surgery, mandibulectomy or maxillectomy, nephrectomy or sphincterectomy, prostatectomy, which is open, 2 pints of blood should be ordered or can be ordered. So colectomy, total or episection, intra-abdominal shunt operations, major vascular procedures, 2 to 3 pints may be ordered. So for cholecystectomy, there is no need to order the blood unless otherwise. Exploratory laparotomy, 0 to 2 pints. Thyroidectomy, 1 to 2 pints. Major spinal surgery, 3 pints. So the following conditions may require the transfusion of a lot of blood and blood products due to maybe other complications. So abruption, placenta, postpartum hemorrhage, PVH, ruptured uterus, ruptured esophageal varices, and major trauma. So on these pints may be ordered more as normal, from normal. So blood transfusion reaction. So transfusion of blood and blood products involves the clinician in the evaluation of the risk-benefits ratio to the patient. So all blood products carry risk of immune and immune-mediated adverse effects, including the transmission of transmission infections, such as HIV, Hep B, Hep C, and malaria and other TTIs. So transfusion reactions are prescribed as acute when they occur within 24 hours of transfusion, and delayed when they occur after 24 hours of transfusion. So this can be days, months, or even years after transfusion, as is the case with some of the TTIs. In this presentation, basically, I'll focus on the acute transfusion reactions. So we have 3 categories on this. So we have mild reactions, symptoms, pruritus, which is itching, signs, localized cutaneous reactions, urticaria and or rash, management of the mild reaction, slow transfusion, administer antihistamines, IM or IV, PO, chlorophylamine. So most of these drugs are not available at our facility. So if they are available, very important to administer them. Promethazine, 6.25 to 12.5 milligrams for children and 25 milligrams for adults. So if no clinical improvement within 30 minutes or if signs and symptoms worsen, so treat as category 2. So on this, so we are supposed to take also the sample to the laboratory for further investigations. So on category 2, the moderate severe reactions, symptoms, anxiety, pruritus, palpitations, mood dyspnea, and headache. Signs: flushing, urticaria, rigors, fever, restlessness, and tachycardia. Possible causes: hypersensitivity. This ranges from moderate to severe. So febrile and hemolytic transfusion reaction. Contamination with pyrogens and or bacteria. These might be the possible causes. So immediate management: seek help immediately from the anesthetist, emergency team, or whoever is available and skilled to assist. Stop the transfusion, replace the infusion set, and keep IV line open with normal saline. Notify the clinician responsible for the patient and blood bank immediately. Send blood unit with infusion set, freshly collected urine, and new blood samples, one clotted and one anticoagulated. So one sample in the red top and one sample in the purple top, from vein, which is opposite infusion site, with appropriate request form to blood bank for laboratory investigations. So very important to do that. So supposed to administer antihistamine, IM or IV or PO. So chlorpheniramine. So most of these drugs, I said, maybe they are not available. So very important to use the available drugs, promethazine, and the like. So give oral or rectal antipyretic, paracetamol, and the like. So never give aspirin. Give IV corticosteroids and the bronchodilators if there are anaphylactoid features. So collect urine for next 24 hours for evidence of hemolysis and send to laboratory. If there is no clinical improvement, restart transfusion slowly with new blood unit and observe carefully. If no clinical improvement within 15 minutes, or if signs and symptoms worsen, treat as category 3. So on category 3 is the life-threatening reaction. So the symptoms: anxiety, chest pain, pain near infusion site, respiratory distress, loin or back pain, headache or dyspnea. Signs: rigors, fever, restlessness, hypotension, which falls of 20% in systolic blood pressure, tachycardia, rise of 20% in heart rate, hemoglobinuria, red urine, unexplained bleeding, which is DIC. Bleeding causes: acute intravascular hemolysis, bacterial contamination, and septic shock, fluid overload, and anaphylactic transfusion associated acute lung injury. So immediate management: seek help immediately from the anesthetist, emergency team, or whoever is available and skilled to assist. Stop the transfusion, replace the infusion set, and keep IV line open with normal saline. Infuse normal saline to maintain systolic BP. If hypotensive, give over 5 minutes and elevate patient legs. So maintain airway and give high flow of oxygen by mask. Give adrenaline. Give IV corticosteroids and bronchodilators if there are anaphylactoid features. Give diuretic, e.g. furosemide, 1 milligram per kg IV or equivalent. Notify the clinician responsible for patient and the blood bank immediately. Send blood unit with infusion set, fresh urine sample, and the new blood sample, which is one in red top and one in purple top, from vein opposite infusion site, with appropriate request form to blood bank for investigation. So check for a fresh urine specimen visually for signs of hemoglobinuria. Start a 24-hour urine collection and fluid balance chart, and record all intake and output. Maintain fluid balance. Assess for bleeding from puncture sites or wounds. If there is clinical or laboratory evidence of DIC, treat accordingly. Reassess if hypotensive, give further saline 20 to 30 mils per kg of 5 minutes. Give inotrope if available. If urine output is falling or there is laboratory evidence of acute renal failure, which is maybe rising of potassium, urea or creatinine, maintain fluid balance accurately. Give further furosemide, consider dopamine infusion, if it is available. So seek expert help. The patient may need maybe renal dialysis. So if bacteremia is suspected, when the patient is presenting with rigors, fever, collapse, no evidence of hemolytic reaction, start broad spectrum antibiotic IV and send blood products back to the laboratory for culture of the contents. So very important to investigate these blood transfusion reactions for further investigation. So when we are investigating this acute transfusion reaction, you are supposed to immediately report all acute transfusion reaction to the clinician as possible for the patient and to the hospital blood bank. So record the following information on the patient notes: type of transfusion reaction, length of time after the start of transfusion that the reaction occurred, volume, type, and the pack numbers of the blood products transfused. So very important, we are having also the registers in the wards. I think not all wards have been given the registers, but soon they will be extended. So these reactions are supposed to be registered in these registers. Reaching this far, these are the references for the presentation. Thank you very much for the being good audience. If there are at all there are questions, they are welcome. Thank you very much.